everyone, and welcome to the premiere of the Colon Channel, a monthly interactive webinar to learn from top Da Vinci general and colorectal surgeons from around the country. You may have experienced the hernia night in America, and we are excited to launch a forum designed specifically for colorectal surgery. Hello, my name is Regina Choi, and I'm on the general surgery marketing team here at Intuitive Surgical. Tonight, I have the distinct pleasure of introducing you to Dr. Jerry Wushner, the Medical Director for the Colorectal Surgery Program at Northern Westchester Hospital. Dr. Wushner is fellowship trained in both colorectal and minimally invasive surgery. Dr. Wushner has completed over 1,000 robotic cases and has published numerous articles in the field of general surgery. He has trained many on his robotic techniques at his hospital, where he'd welcome you for case observations in the future. On tonight's webinar, Dr. Wushner will share his story on intracorporeal anastomosis and discuss the remarkable impact that Da Vinci surgery has had on his patients. Please note that at the conclusion of the presentation, we will hold an open Q&A to answer any questions you may have. So without further delay, Dr. Wushner, the floor is yours.
Thanks very much for the kind words, Regina, and thank you all very much for joining us. I think it's exciting to have so many new opportunities and new technologies that enable us to kind of share our experiences and touch base and learn with so many of our colleagues from around the country. So I appreciate you all taking the time to join, and I'm looking forward to it. So let's get started. If I think about my practice and how I got started, I'd like to just share a little bit about that with you and see if some of you might, as you think about your own situations, might see some similarities. I graduated from medical school in 1988. Which in many regards I think was kind of the sweet spot to become a general surgeon, because I learned how to do open surgery. We were still doing open gallbladders and colons and such. And while I was in my residency is when minimally invasive surgery really started to take off. And I decided shortly into my residency that I was going to focus my career on minimally invasive surgery. There weren't a lot of minimally invasive fellowships at the time. So I found the colorectal program in Baltimore that actually had the highest volume of minimally invasive or laparoscopic colon surgery, and I did a fellowship there, and I followed that up a year later in Virginia at the Eastern Virginia Medical School with a fellowship in minimally invasive surgery, kind of rounding out my practice and my experience with minimally invasive surgery. I came back to New York City, where I'm originally from New York, back at St. Luke's Roosevelt Hospital and Columbia University, and we set up a minimally invasive surgical program. We had a colorectal fellowship, and we were training residents and fellows in minimally invasive surgery. I left and I went to Northern Westchester Hospital. We're about 40 miles north of New York City in 2006. At the time, I was doing approximately 450 cases a year. 85% of my practice was minimally invasive. Excuse me. At the time, I had no interest in robotic surgery. It didn't really make any sense to me. And I think the point of this slide was that in 2006, you would not find a surgeon who was more pro minimally invasive technology than me, who was more pro-technology in general, and despite all of that, I still had really no interest at all in robotic surgery. And when I look back on that and I think about the reasons why, when we talk specifically about robotic colon and rectal surgery, and why not, and these were some of the barriers that I had, and I talk to surgeons from around the country, and I find the same thing, and I want you to think about your experience and where you're at and why we do or don't do things like this. And number one on everyone's list seems to be the learning curve. It's just going to take a long time to learn how to do this. It's going to be difficult to learn how to do this. It's going to be difficult for the OR staff to learn how to set it up. As physicians, we find out we're getting pulled in so many more directions every day. There don't seem to be enough hours in the day to get through what we need to do. And spending an extra hour or 2 hours on a case in the operating room is nothing we really can afford to do for either ourselves or the hospital. It's certainly how are the patients going to do. We're learning a new technique, a new technology. Are we going to run into new problems? Are we going to find new complications that we didn't really have in the past? Are we going to see a higher incidence of the current complications that we already have? Patients' acceptance is certainly a challenge. We're specialists. Patients are referred to us for the most part by a primary care physician, by a GI doctor, perhaps even by a friend or a family member or prior patient. And when they come to you as an expert and you have to explain to them, well, we're going to try something we've never done before, it's a bit daunting to get to understand how that's going to work out and how patients are going to go along with that. And then finally is the cost. I would tell you that I think the one thing that everybody is sure about, even people who know virtually nothing about robotics, are absolutely confident that it is way too expensive and there's no way we can afford to do that. So if you look at this list and think that some of these issues affect you or are applicable to you, and maybe all of them are, I will tell you that this is a slide I pulled from a talk I used to give in 1995 and 1996 when I was lecturing about the learning curve or the issues with laparoscopic surgery. And every point on this slide, really point for point, is exactly what we talked about at the time in the mid-90s, the reasons that we shouldn't or couldn't do laparoscopic surgery, laparoscopic gallbladder surgery, laparoscopic colon surgery. But I'll add to that, there's one new issue that we didn't have back then, and that's this. You know, back then we had open surgery or laparoscopic surgery. Here, everything I'm doing is minimally invasive anyway. My patients are happy. They're having less pain. They're having small scars. They're going home right away. So all is good. So, you know, where's the win? Where's the logic behind, you know, putting in all this effort to learn how to do something like this? If I jump ahead now to my practice in 2017, I told you I came to Northern Westchester Hospital in 2006. I did my first case in 2012 robotically. Done 1,000 cases to date. 40% of my practice is colorectal surgery. This used to be higher. This is relatively stable. This is increasing slowly, but the hernias are what's really increasing, and that's becoming the fastest growing part of my practice, and that's been growing at a higher rate than the other items you see up there. When we talk about robotic surgery, everything we're really talking about is abdominal access. I think we all realize that we're doing the same operation. We're cutting the same structures. We're putting the same things back together. We're not injuring the same things. What we're doing is changing how we get there. And, you know, for the longest time, surgery was done with big incisions, open laparotomies. Laparoscopic surgery came on board, you know, in the late 80s, early 90s, and has been growing ever since. And now we have robotic surgery. In my mind, robotic surgery is not really a third type of surgery. It's not a new type of surgery. I think there are two types of surgery. There's open surgery and there's minimally invasive surgery. And minimally invasive, that's really the one we want to have. That's what we want to offer to our patients. When we started doing laparoscopic gallbladder surgery in the early 90s, we were using instruments that the gynecologists used to do tubal ligation. There really weren't any instruments designed to do laparoscopic gallbladder surgery because nobody was. And industry caught up to that pretty quickly, and we started doing colon surgery and distant fundoplications, and we were doing that with instruments designed to take out gallbladders. Then we started to get, you know, harmonic scalpel was probably the first energy device, and other vessel sealing devices and staplers, and all these things kind of caught up in a hurry. In my mind, robotics is just the next logical progression. It is the next step in minimally invasive surgery rather than a new type of surgery. It's certainly a tremendous evolution in how we do what we do, but it really is just the next logical progression in minimally invasive surgery. When we talk about minimally invasive surgery, I think robotic surgery is just better surgery. You know, I often get introduced as an early adopter of the robotic platform, and I kind of laugh when I hear that because, you know, I came along to this very slowly, almost kicking and screaming. You know, from 2006 on, I had many opportunities to do this, but had no interest in it. In 2012, I went to do a case observation at one of the epicenters, actually in Syracuse, New York, and I looked over the surgeon's shoulder and I saw the robotic view in the pelvis, and my jaw almost hit the ground. The quality of the visualization robotically enabled me to see the pelvic anatomy in a way I had never seen it before. I didn't see it like that laparoscopically. I didn't see it that clearly open. And I would almost make the argument that if the only benefit of robotic surgery was how well you see, it might even be worth it, you know, just for that at all. But there's one other big thing, and that's this, and that's the precision. The fine motion of the instruments, the wristed instrumentation, the ability to get around corners and move at angles without having to torque and lever to get there has really enabled us to do things much more precisely and better. And at the end of the day, there are all sorts of issues surrounding all the surgery we do, but I don't think you can really logically argue that you clearly see better robotically and the instruments are more precise. And at the end of the day, visualization and precision for a surgeon are about as critical as it gets. So once I came back and I decided I wanted to do robotic surgery, I wanted to make that part of my practice and bring that to my patients, I was kind of stuck, well, you know, how am I going to do that? How am I going to get by all of these problems and all of these issues that I had? And I think a lot of people are struggling with some of the same things. So for the next, the time we're sharing together, what I'd like to do is kind of show you what our experience was and explain to you what we learned along the way and how we were able to accomplish our goals and overcome some of these obstacles, or at least perceived obstacles. I'm just putting up a hernia slide here real briefly because we're going to talk a little about the learning curve in general, and I'm sure, as general surgeons, we all probably do more hernia surgery than we do gallbladder surgery, than colon surgery. And I think this is particularly timely. For those of you who get the American College of Surgeons, the surgery news that comes out every month, I got mine this week, and the lead article on the front page says, and I quote, "Robotic-assisted operations, twice the price." And this is data from the Geisinger Clinic, and I looked at that and I said to myself, that's not our experience at all. And I'll talk to you a little bit about our cost structure and what we've looked at and how we look at the pricing or the financial side of it. But we didn't see anything close to that. And if you get by that front page and you look in the article, they're talking about hernias and gallbladders, and they have one chart that looks at their hernia repairs, and they're talking about the surgeries performed from 2007 to 2016. So you're closing in on 10 years worth of surgery, and a total of 19 of the cases were done robotically with an average time of 109 minutes. And 19 cases, for surgeons who've been doing open and laparoscopic surgery for decades, they're probably looking at the first handful anybody ever did. And, how a paper like this is on the front page of any publication is really distressing to me. I don't know how you could draw any conclusion and to get out there and say that this is cost twice the price when you have people who have limited experience and have done so few cases. So it is troubling to me. Our experience was nothing close to that. They have 109 minutes, and again, I'm not going to fault anyone for having long times in their learning curve, particularly at the beginning, but what we found is this. If you look at this graph, we have time in minutes on the side, and on the bottom, we have 8 groups of patients. These are 25 patients in a group. So group 1 is the first 25 hernias that I did. Group 2 is the second 25, the third 25, and so on through 200. And if you look up here, the first 25 patients took us 59 minutes, or right around an hour. Not a great time, but certainly a very acceptable time early in the learning curve. And it came straight down. This is total procedure time. This is skin to skin from the incision to the last stitch being put in. And we are sitting right around 30 to 35 minutes per procedure. We don't have the 15-minute hernias, but we don't have the hour-long hernias anymore either. The robotic technique, it's so reproducible that we are sitting right here consistently. And if you look, we look at all our times we track, so that's the procedure time. Our consult time has come straight down, as we learn. This is time to mobilize the defect from the time we start, mobilizing the sac till the time we're done. Then we place the patch, suture it in place, and then we close the peritoneum. So we track all our times to see how we're doing and see where we are. And we found the learning curve, for hernia surgery to be, very achievable and really not disruptive in any particular way. If we look at colon surgery, and again, back to the learning curve, this is one of the things we worried the most about. Now, this is a paper that we published down from the Eastern Virginia Medical School in Surgical Endoscopy in 1995, and we looked at the first 150 laparoscopic colons we did. So again, the first 25, the second 25, and so forth. And the first 25 cases, the average time is a bit over 4 hours. And in fact, we had cases, here and here. These cases could take 6 or 8 hours. That's problematic for a lot of reasons. You can't obviously spend 6 or 8 hours doing a colon case anymore. And even if you got lucky and had a 3.5 hour one, we didn't know we had a 3.5 hour one, so we didn't have anything else booked that day. And we were really doing one case a day. And that's just not practical. The OR times came down nicely, and the learning curve was somewhere between 35 and 50 cases is where the curve leveled off. And there were several other papers that came out at the same time and showed that that's about what the learning curve is for laparoscopic colon surgery. In a busy surgical practice, again, our time, there are so many, constraints and demands on our time, just not practical. But this is what we found robotically. So the first 25 cases took us right around 3 hours. The curve kind of came down very quickly and leveled off at 150 minutes. So that is our average OR time. That includes a thin patient with an easy right hemicolectomy. That includes an obese patient with recurrent diverticulitis, a low pelvic resection, with neoadjuvant chemoradiation, and coloanal with loop ileostomies and so forth. And I think if you think about in your practice, and you think about the next 100 patients to walk through your door, if the average time skin to skin was going to be 2.5 hours, again, in my world, that's a very reasonable time. We also were concerned about conversions, right? This is the same paper in 1995, and the conversion rate from laparoscopic to open all over the place. 4 patients, 36%, 6 patients up here out of 25. We didn't worry about conversions in 1995 because conversion wasn't considered a complication, nor was it considered a complication now. But if you converted a patient in 1995, they had the same open operation that they probably would have had anyway. The difference is now, in 2017, if you're learning something new and you run into trouble and you end up converting them because you were doing it robotically, it's possible, had you been going with your more comfortable or more experienced technique, the laparoscope, maybe they wouldn't have been converted. So you might be actually denying that patient a minimally invasive approach. What we found is this. We converted 4 out of the first 25 patients for 16%, which is right around the national norm for conversion. We'll talk more about that in a bit. It came, straight down and was sitting right now at about 3% for the entire series to date. And if you take out that first, 4 out of the first 25, the numbers would be even lower than that. So again, if we look here at the first 25 patients, and then here we have the total, 300 patients to date. This is colon and rectal resection. Our conversion rate of 16% is now down to 3. We see our OR time, came down right around 2.5 hours. We show our docking time, we show our consult time, and we have our length of stay. If we want to look at complications, again, this is the first, 300 patients. We haven't had any intraoperative issues, no ureteral injuries, no visceral injuries, anything like that. Postoperative, we'll talk about that a little bit more. We've had 2 anastomotic leaks, 2 MIs. One patient with an anastomotic leak was also the patient who had the MI. Again, I'd like to think the MI caused the leak, but I'm not really sure which way that went. Colitis, DVT, 2 patients with postoperative bleeding that required transfusion. 1 did not require surgery, 1 did. We cleaned out a lot of clot, didn't find any active bleeding. Urinary retention, wound infection rates have been relatively low. Low rate of incisional hernia, but obviously we have to follow that for much longer. That's still it's still early to really comment on that. Let's talk about conversions for a few minutes. This paper was published in the Annals of Surgery in 2013. This is a national review, 3-year period, over 300 academic hospitals and their affiliates. They came up with 36,000 laparoscopic colon resections. And interestingly to me, that was 42% of all the patients done. So essentially, less than half of all colon resections done in this institution were done, laparoscopically. Almost 60% is still being done with an open technique. Their conversion rate, again, almost 16%, and as one would expect, increased morbidity, mortality, length of stay, and also an increased cost associated with converting the case. I thought my conversion rate was much, much lower than that. I think, we all probably think we're a little better than we actually are. I went back and I looked at it and I went through my data for a similar period. I stopped in 2012. That's when I switched to robotic over here. And my conversion rate was 12%. Again, I thought it was better than that, but, that's essentially what it was. Better than the national numbers. Again, I think it should be a little better than the national numbers because I'm a specialist. I do a relatively high volume of this. This 16% includes specialists like myself. It includes people doing, 7, 8 colons a year. So my numbers were a little bit better. Again, robotically, converted 3% are converted to open. And over the last 100 cases, we've converted 1 patient. That improvement in the conversion rate is even more impressive than it looks on the surface because we have now added virtually everybody into this group. There were patients who previously we would have denied a minimally invasive technique. One of the most common things in my practice were the low pelvic tumors. We just couldn't get down there into a low, narrow pelvis, especially in a heavy patient or a male patient. We just couldn't do it laparoscopically. We might mobilize the splenic flexure laparoscopically, then we would go down into the pelvis through a low midline or a Phanestoel. Those were hybrid cases. Certainly if you put them in the laparoscopic group, they would have been converted too. But now these patients are also getting the benefit of a minimally invasive approach. We added an ERAS protocol. If anyone's familiar with that, our protocol focuses on preoperative optimization in the week or so before the surgery, intraoperatively minimizing narcotics, minimizing fluid. We use tap blocks and Exparel into the incisions. We do not use Entereg. early ambulation, very much a team approach, getting the patients out. Our mean length of stay in approximately 65 colons to date is 1.5 days. The range is 1 to 5 days. 60% of the patients go home post-operative day number one. I'm absolutely stunned by this. I continue to be amazed when I walk into the room and I see the patients are essentially, waiting for me to come there so they can get out of the hospital. 92% of the patients are gone by post-op day two. Most of the patients who stay longer than post-op day two, it's an elderly patient with some medical issues that require them to be observed a little bit longer. It's usually not related to the surgery per se. We've had 2 readmissions. The first patient was a 50-year-old male. It was his 3rd resection for Crohn's disease. He had an extensive adhesiolysis. Went home the following day, looked absolutely fantastic. I thought it was a huge success. He came back the next day with an ileus. He had an NG tube, was managed non-operatively, went home on post-op day number 6. The other one was an 80-year-old patient who had a right hemicolectomy for cancer with intracorporeal anastomosis, went home on post-op day 1. This is particularly frustrating for me. He came back on post-op day 6 with a pneumonia. And, I don't think someone gets pneumonia from going home too early, but that's kind of why we send him home early. He stayed for 4 days on IV antibiotics, went home, and ultimately did well. Just a bit about the XI. Again, everything we're going to talk about, you can do with an SI or an XI. And I did most of my cases with an SI until 2014, late in the year when we got our XI. But the XI is really designed for what we do and what we're going to talk about. It's designed for multi-quadrant surgery. That's where the technology really shines, and that's really what the big difference maker is here. If you're doing a gallbladder or a hernia, prostate surgery, hysterectomies, your operative field is really relatively small. Colon surgery, you're going in multiple quadrants of the abdomen, and that's really where the benefits all combined make a big difference for us. I don't dual dock anymore. The only times I would ever dual dock is when I'm in more than 2 quadrants. I'm in 4 quadrants. I'm doing a subtotal colectomy, a proctocolectomy, something of that nature. And the reason we don't dual dock is because we can get to a larger area of the abdomen. We have a much larger space that we can work comfortably in without collisions than we did with the SI. The instruments are longer. That's part of the reason we have a larger space. For those of you who are doing colons with an SI, how many times are you just trying to get around the splenic flexure and you're just not quite long enough, and you can cheat the trocar in and push it as far as you go, and you just can't get there. These instruments are almost 2 inches longer, and that really helps. Setup and docking, much faster, much more efficient. Robot always sits in the same position. Turnover time is much quicker. Setup is much quicker. Breakdown is much quicker. Because the arm profiles are much smaller, and the arms are parallel, you can put the arms much, much closer together. There are much fewer collisions, and particularly in a patient with a short torso or a small torso, that can be a little more cumbersome with an SI, but with an XI, you really have a lot smoother setup and a lot smoother case. Port hopping, you can put the camera in absolutely any port at any time. In addition, use a 30-degree scope, and you just can kind of push a button on the console. The scope goes 30 degrees up, 30 degrees down, much easier than taking an SI scope out, connecting the scope from the camera, disconnecting it, reconnecting it, and so forth. And then again, the quality of the visualization has really gotten better. We'll talk about table motion in a little bit, but again, that's a really nice feature, and it really helps when you're doing multi-quadrant surgery, and that's something that we can do with an XI, but not an SI. So if we can jump in a little bit, let's talk about right hemicolectomy with an intracorporeal anastomosis. I never was going to do a right hemicolectomy, to be honest. I thought it was just such an easy case, I would only do that laparoscopically. And I think from my earlier slides, you can see I'm kind of all in robotically now, but it wasn't always the case. I didn't do hernias for a couple of years because initially I didn't think there was a role for that. I didn't do right colons because I thought they were so straightforward. I did 41 colon cases before I did my first right, and that happened because patients were starting to seek me out more and more, specifically for the robotic technology, as my catchment area grew and patients were coming from much further away. And someone came to me, they needed a right hemicolectomy, and they wanted it done robotically, and I said, I guess so, right? I mean, there's no reason I can't do it. And we did. And that's not a hard case, I don't think, but the hardest part is coming around the hepatic flexure maybe and sweeping the duodenum away. And when I was doing that, sitting there at the robotic console with a nice wristed instrument and everything was 3D, and I'm thinking, why am I not doing all these that way? I just kind of missed the boat on that too. So I added right hemicolectomies, but I was never going to do a right hemicolectomy with an intracorporeal anastomosis because, again, that made no sense to me. I'm doing that same incision. Maybe it's a centimeter or two bigger. I'm taking the specimen out through the same hole I'm doing my anastomosis. So there was no role for it. But if I'm totally honest, the real reason I wasn't doing it is because I didn't think I could. I did suturing. I would suture Nissen fundoplications and things like that, but I never felt comfortable with straight stick laparoscopic suturing to the point that I could suture a bowel opening closed and leave the room comfortably. I just didn't think I could do it. My fear of leaks was way too high. Robotically, we're able to suture so much better, the 3D, the wristed instrumentation, so now I can do it. So the question is then become, well, should we do it? And the answer is there's a lot of reasons why we should do it. Number one, we can now take the specimen out from wherever we want, and we can get off the midline and get away from that midline incision, which is the incision that's going to have the higher hernia rate. The incision is smaller, right? So we're off the midline, a smaller incision, we're going to reduce the risk of incisional hernias, and we'll talk more about that in the next few slides. We're not manipulating and tugging on the colon. We're not pulling the mesentery. We're not trying to squeeze the colon out through a small, narrow incision. We're not going to get that venous congestion and edema because we're working through a small hole with the bowel delivered up through that. We don't have to mobilize nearly as much of the colon. And certainly, especially in a big, heavy patient, not having to mobilize as much transverse colon to pull it out through that incision is safer and it saves time. Proper orientation of the bowel. I've never had an anastomosis fail because it was twisted, but I've seen that at our M&M conferences. And I've certainly had cases where I'm looking at these two loops of bowel and I've tried very hard to keep them lined up properly and I'm ready to put them together and I'm just not sure that one of them is not rotated. And you kind of drop them in, you pull them out, and you put the scope back in, and it can be a time-consuming, frustrating experience. With an intracorporeal anastomosis, you're looking directly at the bowel, you see exactly how it is, you make sure it's not twisted, you make sure the mesentery is proper, and it's much more straightforward. This is debatable. Is there a shorter ileus? There probably is, but these patients, in my experience, are all going home the next day either way, so it's a little bit less clear that has any clinical benefit. There are lots of papers over the years that look at things like hernia rate, compare intracorporeal, extracorporeal anastomosis to each other. I just pulled a few. You can find lots more. This is a paper from the American Journal of Surgery in 2013, and it just shows straight up the midline incision. That's the one with the highest hernia rate, and that's the one we really want to try to stay away from. This is another paper. This is from Surgical Endoscopy in 2010, comparing intra versus extracorporeal anastomoses. This is laparoscopic right hemicolectomy. About 50 patients in each group. Intracorporeal, less blood loss, earlier flatus, less narcotics, length of stay, and overall morbidity are improved in the group that had the intracorporeal anastomosis. This paper also from Surgical Endoscopy last year. It's a retrospective study comparing intra and extracorporeal anastomosis laparoscopically, approximately 100 patients in each group. Again, although this was retrospective, the groups turned out to be very well matched in terms of most of the major things we looked at, BMI, prior surgeries, ASA score, etc. And they found pretty much across the board postoperative complications significantly reduced in the intracorporeal anastomosis group. Surgical site infections significantly reduced. Post-op intervention, so not only are there fewer complications, but the big ones that will land you back in the OR significantly reduced. Now, length of stay reduced, although that's pretty high, and again, the risk of incisional herniation much, much lower in the group. And they basically found across-the-board value to the intracorporeal anastomosis compared to extracorporeal for right hemicolectomy. This is a robotic paper. This is a robotic comparison looking at intracorporeal versus extracorporeal, 48 in each group. Takes longer to do, especially earlier on in your experience. Length of stay again very high, but much lower, but significantly lower. No anastomotic issues and no hernias. So we talk about how to do this. Again, as I said, I do everything with a right. I do all of my all of my robotic surgery with a 30-degree scope, pretty much across the board. I like to use the hook frequently, but I will use the hook or the scissors, not both. If you put your camera in and you think there's going to be a lot of bowel mobilization or lysis of adhesions where you might want some cold cutting rather than thermal energy, I think that's the rationale for doing it with a scissors. I wouldn't use a scissors and a cautery. A fenestrated bipolar, very similar to a Cartier in terms of grip characteristics and profile. This one has energy, this one doesn't. You do not need to use both. It should be one or the other. The tip-up grasper is a very atraumatic grasper. I try to grab the bowel that's staying with that. Anything that's coming out, I can take a little bit more from Cartier, if I need to. The vessel sealer for sealing, dividing the pedicles, the vessels. I'll also use the stapler for that, and then I like the large suture cut needle driver. I think if you're kind of new to it, you may want to stay away from the suture cut and just use a large needle driver, avoid the risk of cutting the sutures. I know some very experienced surgeons who still stay away from the suture cut. It's so much faster, so much more efficient, and once you use it a handful of times, you get very comfortable with it, and it's very unusual that I will cut a suture inadvertently. We're going to talk about port placement, and again, this is kind of XI port placement. The first thing we want to do is we're going to identify the surgical workspace. And this is for a right colon. It doesn't matter whether your pathology is here or here or here. We're talking about mid-transverse colon to the cecum. These steps are what you're going to do for an XI doc. It doesn't matter what you are doing. You're going to find the center of the surgical workspace and target that. When I talk about the center of the workspace, I don't mean where the pathology is. I mean the center of the area you are going to be operating in. I don't care if the tumor's down here or whatnot. This is the center of the operative field. We'll draw a line 10 to 20 centimeters, draw another line across it, perpendicular, and that intersection is where your camera is going to go. I prefer two right-handed ports. You can do two right or two left, and you're going to put those ports in as far apart as you can, but I've had them as little as 5 or 6 centimeters apart when needed, and that works out just fine. If you're going to use an accessory port, an assistant port, I tend to triangulate between these two trocars. You could also put it on that straight line. This is a great setup for a right hemicolectomy without an intracorporeal anastomosis. If it's going to be intracorporeal, I move everything further back. And the reason I do that, this is my 12 millimeter stapler port. If you're right up here with it, you don't have as much room and length to fire that staple. I like to get it as far away as I can. And what that usually translates to is arm 1 is right here suprapubically with a small transverse incision. I'm going to enlarge that to about 3 or 4 centimeters at the end of the case for my extraction. And I'm kind of at this angle. I get that as lateral as possible. And that's how we put our trocars. First thing we always do is we want to do an exploration, right? We're going to look around the abdomen, make sure, the tumor's where it's supposed to be, check for associated pathology. I go medial to lateral, and the rest of the steps I show you are going to be with that technique, but certainly lateral to medial is certainly a viable and a reasonable option. I would encourage you to stick with what you do the best, and if you are a lateral to medial surgeon, I would not change it just for the sake of doing it robotically. You can do it either way. Learn robotically the same technique that you are the most comfortable doing. You can always switch techniques later if you choose to, but either one can be done nicely with the robot. Once I go medial to lateral, I put tension on the iliac pedicle, I make an incision, and to the left of the vessels, I get into the retroperitoneum and I mobilize all the way up to the liver. I identify and sweep the duodenum away from the mesentery, so I'm essentially doing all the mobilization with the exception of the line of Tolt and the peritoneal attachment. I like to leave that attached as long as I can. This is the main reason I don't like lateral to medial is because the first thing that happens is you mobilize laterally, the colon kind of falls in your way. So I save that for the very end. Once I'm done, I'm going to use the vessel sealer to divide the mesentery, the terminal ileum, out to the point that I choose, the location that I chose to transect it. And then I am going to divide the vascular pedicle. I like to use the vascular stapler for this. You can use the overlapping applications of the vessel sealer, certainly if it's thinner if you like that as well. I then come to the transverse colon and I separate the omentum. I get into the lesser sac and I mobilize to the hepatic flexure and then just cut the lateral peritoneum down. And because I've done the rest of the dissection already, my colon is now completely separated. Once I'm completely separated and I've mobilized all of my vasculature and I have my proximal and distal anastomotic sides cleaned off, I then use the Firefly. This is another thing that I did not use. I didn't use the ICG fluorescence because I thought, my leak rate is so low. It didn't make sense to me. I didn't think it was going to help me at all. I will tell you I use it all the time now, and you'll see a bit of it in one of the videos in a few minutes. And it probably changes where I divide the bowel a little more than 5% of the time. I don't think all those patients would have leaked. I think very few of them would have leaked. I don't think it's that exact, but it is just another margin of safety. And if in the next 20 years I have one fewer anastomotic leak because I used the Firefly, it was worth the 20 or 30 seconds I spent doing it. It was worth the $25 I spent doing it 100% of the time. So it really is just another level of safety that I do it all the time. I document it in my operative note as well. Then once we're convinced we have good and confirmed good perfusion, we divide the bowel. I then put the specimen, above the liver or down in the pelvis, and then I do the anastomosis. Once the anastomosis is done, I usually make a fan and steel at that first port site, and I remove the specimen. You can do an iso or an antiperistaltic anastomosis. I do all of them isoperistaltic like this. If you were going to do an antiperistaltic anastomosis, you wouldn't want the stapler in arm 4. You'd want it down in arm 1 in the right lower quadrant. The reason I do this is a technical one. Some people argue it's a less ileus. Again, when we did them open or laparoscopically, we were always doing antiperistaltic over here. But the real reason I do it is when you go to sew this common channel closed, seeing the lowest portion of that can be difficult if you have two loops of bowel coming out this way. As you'll see in the video, since this loop of bowel is relatively short, it's very easy to see. If we could start the first video, please. So this is the anastomosis. We've done all of our mobilization. The bowel is going to be sewn side to side. The transverse colon is running this way. It's cut off down here. The terminal ileum is coming this way. There's already a stitch right here holding this up to the abdominal wall, and that gives us some counter tension. We cut that when we're done. And we're going to sew this in a side-to-side fashion. It's important that this stitch be about 2 centimeters or so from the edge, because when you make your enterotomy and you put your stapler, as you see here, we want to have plenty of room right here. We don't want to have, this suture line too close to the stapler. Right? And this is coming in from arm 4. The staple is now coming straight across. This is almost a straight shot because we've lined up our port with our colon. And we're going to slide this on, kind of grip it but don't close it. And then we can kind of roll and look and make sure we're anti-mesenteric. We want to get it set up nicely, make sure the fat's not there. We fire the stapler and holding on to that traction stitch. This is kind of the point I got to before. You can see you can see this all day. This is the tough part to see. But because this loop of bowel ends here, you don't have a whole other loop of bowel coming this way. You get a really good view of the bottom of the anastomosis. That's a running 3.0 VLAC stitch, and now I'm doing 3.0 Vicryl Lembert sutures on top. I do this as a 2-layer hand-sewn anastomosis for my common channel after the side-to-side staple. If we can go back to the presentation, please. So if this is something that you're interested in doing and you want to kind of bring this to your practice, I think there are a couple of ways to kind of get going. Certainly, I would advocate doing extracorporeal anastomoses first, right? Start out, get comfortable handling the bowel, figure out the port placement, the procedure steps, how you're going to divide things, and how you go through the operation. And then when you feel comfortable with that, is a reasonable time to get into the hand sewing and the intracorporeal anastomoses. There are lots of good ways to learn to suture. Certainly for the general surgeons out there, if we're doing hernias, I kind of describe that as low impact or low risk suturing. If you are suturing the peritoneum closed and you have a problem, you can fix it a lot easier than you can fix an injury to the bowel. If you have access to a robotic simulator, again, another great way to get comfortable with the technology. Clinical video reviews are available online. There are all sorts of online forums as well. These are closed groups. These are Facebook groups, but any surgeon, any physician can join them. Just jump on and ask for access. It's pretty straightforward. Case observation at one of the epicenters or case observation sites, and certainly courses are available to you as well through labs around the country. To talk about a little bit about sigmoid or left colectomy real briefly. First, we'll talk about port placement and docking, and if you look at this picture here, this is almost a mirror image of the right colon. So again, I don't care if the tumor is here, there's diverticulitis here, the tumor is here. This is our surgical workspace. This is the left colon. So somewhere in the middle of that workspace is your target. We're going to draw that 10, 20 centimeter line, another line across it. What this often translates to is this is kind of a right paramedian incision for the camera. I like 2 right-handed, 1 left-handed ports, and then I triangulate out to get my assistant port in. And we really use the assistant port mainly as an air seal port for our pneumoperitoneum. We're going to do our assessment, right? Are there adhesions, any associated pathology? Do I have to get down into the pelvis? Do I have to mobilize the splenic flexure? Sometimes the splenic flexure is very low. There's a long redundant colon. Maybe it's distal diverticular disease, something of that nature. Once you've figured out what you have to do, you have to figure out the table position. Now, if you do not have table motion, we usually set up in kind of a neutral position where the table is kind of, you're set up to do the pelvis, but you can also get to the splenic flexure, but maybe not great exposure to either one. I think the key really is you have to use as much Trendelenburg as necessary to get the bowel away from the pelvis and the rectosigmoid junction, but just enough, because the more you do, then you can end up with the bowel sitting on top of the stomach, the transverse colon, the splenic flexure, and you're going to make that more difficult. If you do have table motion, you decide the same thing. Do I have to mobilize the flexure? What do I have to do? And then you select the order of steps. I always like to mobilize the splenic flexure first. So if I run into trouble with a complicated part down in the pelvis and I have to open up, maybe I'm only making a lower midline incision because the splenic flexure is done. So what I'll do is I'll start with the patient in the head-up position. I will mobilize the splenic flexure, come down the gutter, then I will use table motion to go in the other direction. For those of you who aren't familiar with table motion, it basically gives you gravity back. You don't have to undock the robot. You don't have to separate the arms. You take one instrument out because you have to have control of everything that's in the patient. So you basically have the camera and 2 instruments in. You don't undock the 4th arm. You just take the instrument out, and the table moves, and the robot moves with it. You can, again, lateral to medial or medial to lateral. Whatever technique you do is the technique laparoscopically, is the technique you can do robotically. We'll divide the vascular pedicle. Again, I like the vascular stapler for that. Then I use the Firefly, confirming that I have perfusion. Then I transect the rectosigmoid or the rectum, depending on what the disease process is, and remove the specimen. If we can now start this next video, please. This is just a quick clip showing you what table motion will do. You have in the insert over here, you have the room view, and you can look down here at the bottom, and you see the horizon. The bed is level now, and as we go head down, the bowel is just falling away out of the pelvis. You see in the top left, the way the robot is angling is the table angles. In this particular case, the splenic flexure has already been taken down. You can see we can move the instruments while the table is moving, so we can work while the table is moving. We get the bowel out of the pelvis, and we're all set. And we're ready for the next part of the operation. Let's go back to the presentation, please. Just to touch base about the flex joints really quickly, and this is one of the really nice features of the XI robot that has really made a